Thank you to the Fordham Research Consortium on Disability for having me today as part of the interdisciplinary seminar series. I'm excited to present to this group on some recent findings that reveal changes in the social patterning of autism diagnosis. The work I'm going to present is joint with your own Christine Fountain, as well as with Keely Cheslak-Postava and Peter Behrman, both at Columbia. Autism is a neurodevelopmental disorder that is defined by challenges in social interaction and communication, and often by repetitive, restricted patterns of behavior. Autism does not have any definitive biological markers, so diagnosing autism relies on recognizing its symptoms and then being able to access diagnostic services. Rates of autism diagnosis have risen dramatically over the past few decades. These are the CDC's estimates of autism prevalence rates for the United States. We can see that they rose from 6.7 per 1,000 children born in 1992, or roughly 1 in 150 children, to 18.5 per 1,000 children born in 2008, or 1 in 54 children. Born in 2008, or roughly 1 in 54 children. So the prevalence rate more than doubled over these 16 birth cohorts. Since these estimates come from the CDC, one might reasonably expect that they're based on information from millions of children, or maybe a representative random sample of children from across the country. But for most of these years, they're actually based on data from 11 locations that are scattered across the country and are mostly sampled from metro areas, and so not necessarily representative of the full United States population. And I point this out because it speaks to the broader challenge of accessing data with reliable autism diagnoses for populations that are large enough to be able to study autism's risk factors and social patterning. I'll show in a little bit how at least we believe we meet this challenge. But in the meantime, based on these data, also on national special education data and some other samples, researchers have studied the social patterning of autism diagnoses for children born in these cohorts. Before describing what these researchers found, it's helpful to have a little background on the social patterning of health more broadly. So typically, people of lower class or socioeconomic status and racial minorities experience worse health than people of higher socioeconomic status and people who are white. In fact, because of the enduring nature of these relationships between socioeconomic status, or SES, and health, and between race and health, sociologists have come to think of SES and race as fundamental causes of health. The idea isn't that SES or race themselves cause health or disease, but that our society is structured such that social conditions and structural racism are important determinants of what resources people do or don't have. Because of our social conditions and racism, people of higher SES and whites tend to have more resources than people of lower SES and racial minorities. And more resources allow people to access health information, to avoid health risk factors, and to access healthcare, all keeping them healthier. But thus far, rates of autism diagnosis have been an exception to this general rule. Researchers have found that autism prevalence rates for children born through roughly the mid-2000s were lower among Hispanic children relative to white children. Depending on the data set, they might be higher, lower, or similar for Black children relative to white children, and lower among children of lower SES parents relative to children of higher SES parents. As I just described, this is the opposite of health disparities that are observed across almost all other health outcomes. But these patterns make sense in light of the fact that for children born through the mid-2000s, obtaining an autism diagnosis required a significant amount of resources. So I mentioned earlier that there's no biological marker for autism, and so diagnosis is conditional on knowing what autism is, recognizing the symptoms, and securing a diagnosis from a healthcare professional, often a specialist, who is either willing to screen the child or maybe who brings up the possibility themselves. And so each of these steps requires resources that tend to be more available to more advantaged social groups like whites and those of higher SES. So in the case of autism, fewer resources instead of worse health has meant a lower likelihood of diagnosis. And there is some empirical evidence that this is the case, that the patterns in autism diagnosis shown here are at least partially attributable to differential ascertainment of autism between these social groups. So one study found that autism was less likely to be ascertained among Black and Hispanic children relative to white children in the CDC's data for the 1994 birth cohort. And the SES gradient in autism diagnoses that is observed in the United States is not observed in Sweden or Finland, places where healthcare and developmental screenings are more easily accessible. More recently, though, knowledge of autism has become more widespread, and states and medical professionals have been working to improve systems for ascertainment and diagnosis. So, for example, in 2006, the American Academy of Pediatrics recommended universal screening for autism during 18-month well child visits. If this recommendation were to be fully implemented, it would make parents' access to knowledge about autism much less important for securing a diagnosis. So, has the social patterning of autism diagnosis changed since the mid-2000s birth cohorts? There is some limited evidence that it has, but this evidence tends to rely on special education data, which has very limited information, or on county level instead of individual level measures of social characteristics. And so to provide a more complete picture of the recent social patterning of autism diagnosis and whether it has changed in recent years, we calculated autism incidence and prevalence rates based on clinical diagnoses for the population of California, which is the largest state in the United States in terms of population, across 25 years. In California, children and adults with developmental disabilities, including autism, are entitled to services provided by California's Department of Developmental Services, or DDS. Diagnoses are either confirmed or determined by qualified professionals at the DDS. Enrollment with the DDS is voluntary, but since the DDS provides services without any financial conditions, most people with autism in California are enrolled. We linked the DDS's caseload records from January 1992 through November 2019 with the birth records of all children born in California in 1992 through 2016, which is a little over 13 million children. And doing this allows us to know which of the children born in California have been diagnosed with autism. Until 2014, the DDS provided services only to individuals diagnosed with autistic disorder, not to people with other disorders on the autism spectrum. But in 2014, the DDS adapted the new edition of the Diagnostic and Statistical Manual, or the DSM-5's diagnostic criteria for autism spectrum disorder, and began providing services to people diagnosed with autism spectrum disorder. And so that includes what was previously autistic disorder, as well as other disorders on the autism spectrum. We linked the DDS records and birth records probabilistically using children's first names, last names, birth dates, sex, and race ethnicity, and manually reviewed uncertain matches. So overall, about 84% of the DDS records were matched to a birth record. Those that didn't match were probably born outside of California and are not part of our analysis. So this linked data set is the largest available data set of clinical autism diagnoses. and it provides us with a good amount of information, including whether children have comorbid diagnoses of intellectual disability and their mother's race. It also provides us with two measures of socioeconomic status: mother's education level and whether the birth was paid for by Medi-Cal, which is California's Medicaid program. So to give you a sense of the population of children born in California, you can see here that 47% of their mothers are Hispanic and 31% are white. About 45% of deliveries were paid for by Medi-Cal, and their mothers' education levels are relatively evenly split, with a slight majority across these birth cohorts not having completed high school. And in the top row, we see that a little over 100,000 of the people in our data have been diagnosed with autism. So I'll now turn to California's incidence and prevalence rates of diagnosed autism. And maybe I should have said at the beginning, if there are any clarifying questions while I am talking, feel free to interrupt. So on the left here are the incidence rates of diagnosed autism for children aged 3 through 6 in 1998 through 2018. So that's the number of children aged 3 through 6 who were newly diagnosed with autism in each year per 1,000 of all children aged 3 through 6 in that year. And we see that the diagnosed autism incidence rate in California rose from about 0.5 per 1,000 3 to 6-year-olds in 1998 to 3.5 per 1,000 3 through 6-year-olds in 2018. So that's about a 612% increase. And most of that increase was among children who do not have comorbid diagnoses of intellectual disability. If we look more closely, incidence rates rose relatively steadily from 1998 to 2008, sort of declined and then plateaued a bit between 2008 and 2010, and then increased again between 2010 and 2018, with especially large increases after 2013, when the DDS adopted the DSM-5 criteria for autism spectrum disorder. On the right are the prevalence rates of diagnosed autism by birth cohort. So that's the number of children born in each year and diagnosed with autism by November 2019 per 1,000 of all children born in that year. The prevalence rates look like they flatten and then decline for the last few birth cohorts because children born in those cohorts haven't yet had as much time to be diagnosed. So if we focus on 2013, which is the last birth cohort for which we have complete information through age 6, when most people have been diagnosed, we see that prevalence rates rose from 3.5 per 1,000 people born in 1992 to 14.5 per 1,000 people born in 2013. So again, a really big increase. Moving forward, I'm going to focus on autism incidence rates, so graphs like the one on the left. But like we see here for intellectual disability, the patterns I'm going to show would be the same if we were to look at prevalence rates instead. So it's well established that autism diagnosis is more common among boys than among girls. And that's what we see here. Incidence, though, has continued to rise for both boys and girls. And there's been just a small decline in the male to female ratio, or the ratio of the male incidence rate to the female incidence rate, with a ratio of about 3.6 in 2018. The social patterning of diagnosis by race, though, has changed considerably. So in the late 90s and early 2000s, children of white, Black, and Asian mothers had similar rates of autism diagnosis in California, and rates were lower among children of Hispanic mothers. But since 2008, autism diagnosis among children of white mothers has slowed, and by 2014, they had the lowest diagnosed autism incidence rates. Diagnosis among children of Hispanic mothers, on the other hand, rose sharply, especially beginning in 2013, eventually catching up with the rates of children of Black and Asian mothers. And so this marks a pretty dramatic shift in recent years in who is being diagnosed with autism. And here we see another dramatic shift. So in the first half of the years that we study, diagnosis rates followed the education gradient we would expect given the importance of resources for securing an autism diagnosis. With more education, incidence rates are higher. But by 2018, diagnosis rates were not highest but lowest among children of mothers with at least a college degree. Looking at incidence rates by another measure of maternal socioeconomic status, Medi-Cal receipt, puts this finding into even starker relief. So rates of autism diagnosis, as we said earlier, have historically been higher in the United States and in California among people of higher socioeconomic status, or people who do not receive Medi-Cal in this case. But this long-standing finding reversed in California in the 2010s, which we see here in the lines crossing paths with each other. We know, though, from public health research, as well as from research in many other fields, that race and class don't just matter in our society independently, but also in interaction with each other. So, for example, the hardships that come with being poor for someone who is Black are, on average, more severe than the hardships that come with being poor for someone who is white. And so we next looked at diagnosed autism incidence rates by race and SES simultaneously. And doing so tells a more complicated story. So from 1998 through 2008, diagnosed autism incidence rose basically for all racial ethnic groups, regardless of Medi-Cal status. But after 2008, if we focus on the top left graph, incidence rates decreased and then rose at a slower rate among children of higher SES white mothers, who are represented by the solid blue line, while increasing steadily throughout the period among children of lower SES white mothers, represented by the dotted blue line. And so this resulted in an SES reversal for children of white mothers, similar to the graph that we just looked at for the full population. Children of Asian mothers, the bottom right graph, show a similar but a little less pronounced SES gradient reversal. But among children of Hispanic and Black mothers, the gradient did not reverse, and rates of autism diagnosis are generally higher among those of higher socioeconomic status, here defined as people who do not receive Medi-Cal or the solid lines. So the socioeconomic status gradient reversal we observed on the last slide is really only true of children of white and Asian mothers. These figures show that the results that we just looked at hold in a regression framework when we account for a number of other characteristics that are known to vary by autism status, social class, and race. To make these figures, I ran logistic regression models predicting autism diagnosis, and I ran separate models for each birth cohort and by maternal race. Here, I am showing the odds ratios for each model for Medi-Cal status and their 95% confidence intervals. So circles whose vertical lines don't cross the horizontal line at 1 are considered statistically significant. And we see that when accounting for the factors that are listed on the bottom of the slide, among children of white mothers, so the figure in the top left corner, Medi-Cal receipt was an insignificant predictor of autism diagnosis, but then became a positive predictor of autism diagnosis for more recent cohorts. In contrast, Medi-Cal is generally insignificant as a predictor of autism diagnosis for children of Black, Hispanic, and Asian mothers when we account for other relevant factors. And so this confirms that the social patterning of autism diagnosis by class changed for children of white mothers, but did not change for children of other mothers. Finally, we know that one's own individual characteristics aren't all that matter for one's health or for having the resources to obtain adequate healthcare. The neighborhoods we live in matter too. And we wondered whether these patterns might vary by neighborhood resources, which we measure as the poverty rate of each child's zip code. So here we're looking at results from the same logistic regression models that I just described, but instead of looking at odds ratios, we're looking at predicted probabilities of autism diagnosis for children of white mothers. The left figure is for people with Medi-Cal, and the right figure is for people who don't receive Medi-Cal. The blue lines show predicted probabilities for children who live in neighborhoods at the 10th percentile of the poverty rate, or low poverty neighborhoods. And the orange lines show predicted probabilities for children who live in neighborhoods at the 90th percentile of the poverty rate, or high poverty neighborhoods. We see on the left that neighborhood poverty doesn't really matter for the likelihood of receiving an autism diagnosis for families who receive Medi-Cal. The confidence intervals for the two lines largely overlap. But for families who don't receive Medi-Cal, shown in the graph on the right, those in lower poverty neighborhoods are a little less likely to be diagnosed with autism than those in higher poverty neighborhoods. So among children of high SES white mothers whose rates of autism diagnosis we've seen have been plateauing relative to the other social groups we've looked at, it's high SES white families in high SES neighborhoods for whom the plateau is most pronounced. But for children of Black, Hispanic, and Asian mothers, neighborhood SES doesn't really matter. The confidence intervals here overlap for Medi-Cal recipients and also for people who don't receive Medi-Cal. Here, I'm just showing that for children of Hispanic mothers as an example. So like before, the difference is really only apparent for children of high SES white mothers. So overall, rates of autism diagnosis continued to rise in recent years in California, but who is diagnosed changed during our study period. By 2018, children of Black, Hispanic, and Asian mothers were diagnosed at higher rates than children of white mothers. And among children of white mothers, children of lower SES were diagnosed at higher rates than children of higher SES. These reversals bring the social patterning of autism diagnosis in line with the social determinants of health I discussed earlier. And they're important because an autism diagnosis confers access to helpful services, special education services in school, and in California, services through the DDS that might include respite services, transportation, or day programs. But why did these reversals happen? Well, we have a couple of ideas that we're working now on exploring. So the reversals can be thought about sort of in two parts: a faster rise in diagnosis rates among children of lower SES parents and parents of color, and a slowing down of the rise in diagnosis rates among children of high SES white parents. There are probably multiple factors that account for the recent faster rise in diagnosis rates among children of lower SES parents and parents of color. I talked earlier about the importance of access to knowledge and resources for obtaining an autism diagnosis, and there have been multiple efforts in recent years to increase awareness of autism and access to diagnostic services. I mentioned the American Academy of Pediatrics recommendation for universal screening. A committee within California's state Senate has worked toward improving linguistic and cultural competency at the DDS. And autism generally has very strong advocacy within the United States. So all of these efforts have likely contributed to the faster increase in autism diagnoses among children of lower SES parents and parents of color, and in turn help to broaden access to services for these populations. what about the slowing down of the rise in diagnosis rates among children of high SES white parents? So one possibility is that children in this population have reached or are close to full ascertainment, meaning that all children who have autism have been diagnosed, while ascertainment among children of lower SES parents and parents of color has historically been low. So if that's the case, then what is emerging now is the quote unquote true social patterning of autism diagnosis. Another possibility is that as more children of lower SES parents and parents of color are being diagnosed with autism, an autism diagnosis is becoming less attractive to high SES white parents, and they're shying away from or no longer pursuing the diagnosis and its associated services for their children. So if you have any thoughts about these explanations or kind of any ideas for other explanations, I'd love to hear them afterward. But in general, our results show the importance of the social systems that shape ascertainment and show that health outcomes in the United States continue to be fundamentally shaped by the social systems that we've built around social class and race. So thanks, and I look forward to your questions.